Okay.
Okay, hello everybody, and thank you for joining us. This is Michel Akkad with my co-host Anish Koka, and this is episode number 14 of the Akkad and Koka report. And before I introduce our guest, I would like to announce that we finally have our podcast show up and running, so you can subscribe on iTunes, and you can do so by visiting our website. We also have now a website, akkadandkoka.com, akkadandkoka.com. And this particular episode will have its show notes on at akkadandkoka.com/episode 14. So our guest today is Anupam Singh, who is assistant professor of internal medicine at Santosh Medical College in Ghaziabad, India. Dr. Singh obtained his MD degree from the Rajendra Institute of Medical Sciences in Ranchi, India, and did postgraduate training in cardiology at Hindu Rao Hospital in New Delhi. And his research interests are varied and include tuberculosis, asthma, point-of-care ultrasound, and quantitative methods of prediction in medicine. And that's the reason we're having Anupam with us today, because he had the gall to disagree with us on some points of EBM, or at least to disagree with Anish. So Anupam, welcome to the show. We're delighted to have you.
Great. I'm equally thankful to you for inviting me here. It has been a pleasure to listen to you and to your podcast and at the various, at your channel. So it is always informative. Yes.
Very good. So Anupam, let me give to the audience a little bit of the context of this conversation. Anish wrote 3 blog posts recently on the healthcare blog website. Criticizing a little bit, more than a little bit, criticizing a common EBM mentality, if I put it that way, sort of this attitude of really going to randomized controlled trials as the final authority in how we should practice medicine. And you pushed back a little bit. And my impression of your position is that it's a common position, is that people recognize that randomized controlled trials have limitations. But a little bit, it's like what Churchill said about democracy. Democracy is really lousy, but it's better than all the alternatives. So randomized controlled trials have a lot of problems, but it's the best that we have, and therefore we shouldn't dismiss them so easily. Is that a fair rendition of your position? And would you like to elaborate on that?
Yes. For many for many things in medicine, we can't have randomized controlled trials like a diagnostic process, right? But say in estimating the effect size of a therapy, right? So it is always good to have a control. We have already heard of the leeches and everything. There are some difficulties in assessing the exact effect while we are practicing. But again, at point of care, we have to apply the results of the randomized controlled trial to our practice. Doctors should do the interpretation of the randomized controlled trials. One thing I have problems with the evidence-based medicine, or it should be rather evidence-informed medicine movement, is that it is taking the p-value dichotomy too far. Obviously there can be dichotomy, but in the pioneers of the EBM movement, Sackett, Gayat, these guys advise us to look at the estimates, the confidence intervals, and to point out and to evaluate the evidence according to our clinical significant, what we think is the clinical significant difference. I think that few people are doing that, and that is why that brings me to the point that started the RESPECT trial, the PFO trial, which was in 2013. According to me, the evidence was pretty clear. That we had an RCT favoring the PFO closer, and still, the people were so. The trial was a bit underpowered. I don't know why they stopped it so early, but again, people were so they still continue to deny it. In fact, AN issued a statement that the evidence is not conclusive, but if you look at the confidence intervals and effect sizes, you got a fair perspective that it works. Yes.
So let me just, for the audience, people in the audience who don't know about this was a randomized trial of a device to close a cardiac defect with the view of preventing strokes. And the trial was negative as far as reaching statistical significance according to p-value, but there was a strong trend, and people reading through the tea leaves, like you and Anish, thought that the trial was actually, in a way, could be interpreted as being positive and or showing that that PFO closure helps. Anish, do you have any comments about that?
Yeah, no, I'm glad that I've convinced Anupam so quickly. I think I understand the differences seem, at least as elucidated by Anupam, seem more minor than, but essentially Anupam is saying that the problem is with the interpretation of the RCTs, not so much the RCTs itself. And I think I'm generally saying the same thing, but you know, I think we are trying too hard to convince lay people of what's going on. Meaning, I think this is why we're in the pickle we're in, right? So I'm glad Anupam is also kind of speaking out about the wider practice of evidence-based medicine, and that it kind of leaves logic behind, leaves our understanding of biology and pathophysiology behind. Those things are very much still important, and it's a major problem because you have some of the the big stalwarts, the instructors, the folks that are training the younger generation, who run around saying that it's way more important to learn statistics in medicine in medical school than it is to learn biology and pathophysiology. Nobody cares because there have been dead ends in biology and pathophysiology. Forget that. What we need to do is understand statistics. Medical students need to understand statistics. That's what's important. And I think that's absolutely false. I think the best way to muddle your way to the truth is by having subject matter depth, and medical school is absolutely for biology. It absolutely is to understand physiology, to understand pathophysiology, to understand the history of medicine. Otherwise, we're kind of totally lost.
So, Anupam, let me ask you to clarify a point that you said that it's important to understand the point estimate of an effect. Why is that important? I mean, if by your analysis of the PFO trial, closure was offered a slight improvement over non-closure, what measure of improvement do you think would satisfy you, or in what way does that help you to know that it's better by 5% or better by 10% or 20%?
I mean, that is open to interpretation. I mean, obviously, that is where we have to exercise clinical judgment, and that depends upon the cost of the therapy, the patient affords it or not, and the risk assessment that you do. The effect size is important because I got to convince my patient, right, that this is some amount of almost, if you believe it in a Bayesian sense, that 95% people will have something effect size between this and this. So it gives you some sense of effect size. Otherwise, we have very large trials which are clinically insignificant, right? So we have to have some amount of this drug. Is it cost effective, at least in India where I practice, with regards to the cost, with regards to the harms? So that I have to decide. The only thing here is the clinical significant boundary is to be decided according to my judgment. And that thing, I think that is missing. I mean, many people, they do it intuitively in the practice, but many people tend to dismiss it. They don't exercise the clinical significant difference kind of argument. They don't draw their own boundaries. Everyone should draw their own boundaries depending upon the patient's assessment, depending upon the values. I mean, obviously the discussions with the patient and what you figure at point of care. Yes, that is my point.
But doesn't that defeat a little bit the purpose of the EBM movement in general, of trying to rein in the clinical judgment of doctors, who precisely are, can have their own, their own biases to do things, and therefore may not, if your judgment is X, and I don't disagree with you, by the way. I mean, I definitely think that clinical judgment is very important, but I'm trying to understand why make such a big deal about a hierarchy of evidence and so forth. Clinical trials are helpful, but I think we have to understand also in what way they're helpful, even if they're extremely well done, and in what way they're actually not all that helpful. Anish, you have something to say here?
Well, yeah, I mean, just to follow up your point, Anupam, just to particularize it. Like, I mean, part of the problem is that when I try to have these conversations with folks, it gets lost in all these generalities and the general heuristics, which become hard to apply in any specific place. So, for instance, this idea of how can we effectively counsel our patients if we don't have an average treatment effect? Take PFO, since we're talking about it, right? How do we, the question ultimately boils down to, doctor, should I get this? What do you think? Should I get this procedure or not? It's a yes/no thing. I don't know. And yes, you can say the hazard ratio in RESPECT was 0.5, right? But there's so much more that's involved in what that trial, for instance, that showed us. So, for instance, there were 16 strokes in the patients that were randomized to medical therapy. And there were 5 strokes in the patients that were randomized to closure with a device. Only one of those 5 patients who had a closure with a device had a massive stroke. 9 of 16 patients who were randomized to medical therapy had massive strokes. So, there's so it's nice to have these numbers to confidently say, your risk of having a recurrent stroke will reduce by 50%, and the confidence interval, the lower bound is 0.2, and we can say all sorts of different things. But there's so much more that goes into that question. So when that patient asks you, doctor, what should I do? I've had a stroke. I have a PFO. What do you think I should do? What do you recommend, right? This idea of shared decision making, and I will tell them that there's a 10% reduction based on the trial which shows this. I find that to be I find that treats us more than it treats them, or rather, all of us want to feel better about the fact that we've quantified something, and therefore it sounds better. But in the end of the day, that yes or no, or how you counsel the patient is much more complicated than the average treatment effect and or even the confidence interval.
What
do you think, Anupam?
Yeah. I think you are reading EBM in a too restricted fashion, or people practice it. Certainly, if you see Twitter or something, in general, the training of EBM is certainly like that. By the way, I also believe that medical students should be trained in just basic statistics. They should learn pathophysiology, because we are not here to be statisticians or mathematicians. We are not there to solve any differential equations, and we can never be as good at them. Our goal is to generate hypotheses, to see the outliers, and that would act as, for further clinical hypothesis generating things for clinical trials. Example I would give you, the people who actually did clinical trials, forget the Twitter, cults or something like that. But they actually saw, even on the basis of after the RESPECT trials, they did an individual patient meta-analysis, and when you wrote the blog, that was when FDA approved the device. Right? That was the exact time, despite all the trials being negative. That's an important difference. And despite the AAN, the Academy of Neurology, which in my view wrote a very, it was a bad, its recommendation didn't make any sense to me. So
So,
many people smarter than us, I mean, those people who are actually doing trials, I mean, and their business is all around that. I mean,
Right.
this is what they do, right? They are smart.
Right,
I mean, what you are pushing back against is, I think, some Twitter, the left is more or some specific.
That's true. But Anupam, I mean, what I saw in the U.S. at least in practice also was that there was a massive chill. So there were probably too many PFOs that were being closed before the RCTs came out. Like every single PFO with somebody who has a TIA was being closed, right? And then suddenly, after the trials came out, this is how we are so in the clinical world. We're so dichotomous, and we're so trained to think, well, P was 1 to 6. So the massive news was they were negative, and so I can tell you, massive drop off in the number of PFO closure devices that are placed. And I wrote in the thing that thank goodness people smarter than me in the FDA also saw what we saw. But I think the overwhelming push and the overwhelming thought among a large number of physicians, I would say the majority of physicians. So I don't think I'm just pushing back against a cult. I'm pushing back against what I saw, which is the fact that very few PFOs started or were getting closed.
Anupam, how do devices get approved or treatments get approved in India? Because in a way, as far as I'm concerned, it's primarily the FDA that is pushing this dichotomization of how we view treatments. Because for a treatment to be approved, it has to go through FDA, process, and the FDA process is really the dichotomy of the clinical trial. I think I don't know how. I think it's pretty exceptional what happened to Respect, that the device was approved despite not meeting that p-value significance. Am I correct?
No, I don't think so, because I mean, the previous closer one and EC trials, they were way too underpowered. I think to call it negative trial would be, misunderstanding EBM altogether. They were way too underpowered to detect anything. Even the Respect trial had a trend, it was a significant trend. If you are a Bayesian like me, I mean, if you calculate the probability, so you could make a sense that this thing was, if it carried out longer, so it would very well have been significant.
No, right. But what I'm saying is that it's very rare for the FDA to approve a device that does not technically meet a p-value threshold, right?
I understand, but this is a device trial. I think they frequently do adaptive designs in device trials. I don't know what was happening, and so they do a variable. Generally, the guidelines are 2 values. You have to have 2 p-values, 2 RCT, 2 p-values less than 0.05, or 1 p-value less than 0.001. I think that is the standards FDA adopts. But again, I mean, people in India, we generally follow European standards, so the drugs are approved pretty quickly, and we get devices and drugs faster than US. But again, it is the US which does the most of the innovation. So,
and educate us, the Indian system or the European system, is there not a proof of efficacy that is required, or is there a proof of efficacy but the
yes,
it's more permissive?
Yeah, so it's definitely more permissive than FDA. In Indian standards, a phase 3 RCT, one of the centers has to be India for that drug. If that drug is approved from FDA or even the European standards, then one of the places, at least some Indian centers, must be there in that for that drug approval. So that is the standard in Indian case. Right now, we are having a similar issue in bedaquiline. Bedaquiline is a drug for multi-drug resistant TB. It was an oral drug which cured more patients of multi-drug resistant TB, but it also killed more in a phase 2 RCT in USA. So that is why, I mean, so right now, compassionate use has been granted for XDR variant, which has a high case fatality rate. But again, for MDR TB, so the phase 3 RCTs are going on here. So even after that, because TB is a big problem in India. So this is the general sense of things. And in general, this is how, and generally the drugs approved, for example, inhalers, many inhalers I visited US once, so the many inhalers, we had it. We were using cyclosamide and everything, inhalers, and in US that was not available because the FDA is more, restrictive. I mean, it treats to a higher standard.
So are you happy to have a bigger armamentarium of medications to use for the treatment of asthma than if you were practicing in the US?
Sure. I mean, that go obviously, as you said, that even in US, I mean, people, but the problem is what Anish has said has a ring of truth to it. I mean, despite being trained in EBM, if all we are doing is dealing in dichotomizations of negative trials based on P.05, then it ought to be dumped. Or the frequentist paradigm, which I say that you don't have to incorporate any prior information. I'm not a fan of that. I mean, EBM means that, or evidence-informed medicine is useless if you don't bring your own sense to it, and you have to personalize care. That is why I am also not fond of absolute risk ratios. I'm for absolute risk reduction. So I prefer ratios. Still, it helps me a bit. I mean, obviously, the generalizability of an RCT, and these are concerns, but still, I mean, I can, titrate it patient to patient depending upon his risk or her risk. So I'm not a fan of ARR or NNT. Again, that has dumbed down the EBM or evidence-informed medicine. That is why I see that EBM cult. Too many people are, very smart people are, thinking in terms of significance and non-significance, or sometimes less is more movement. I mean, if you belong to less and more, so even the inconclusive trials get branded as negative ones. I see that very often. And again, when you are a fan of more is more, you have the clinically insignificant trials, but statistically significant that get branded into more and more. So, but again, this thing doesn't have an easy solution. You can at least try to quantify your biases a bit by being a Bayesian. For example, I'm skeptical. Most drugs have small effect. So you can try to quantify a bit just for demonstration purposes, just for teaching purposes. At point of care, no one is solving differential equations or doing utility calculations. That is just for demonstration purposes. More than the EBM, I think the EBM teaching is flawed. Or if we are teaching so much EBM, then and people are still making decisions on base of positive or negative trials, then it is seriously flawed. Yes.
So I think what you say sounds perfectly reasonable to me. There is, you're trying to, you're looking back on the founders of EBM and saying that they didn't want it to turn out the way it has, but I'm not sure that they were so clear about that, because they viewed EBM as a tool for decision-making, for clinical decision-making, not just as a tool for a better appraisal of clinical research. And that's confusing because in a way, yes, as a tool for better appraisal of clinical research, I'm all for it. There's no question about it. You can evaluate critically clinical trials, case series, observational studies, what have you. And that's very good, but from the get-go, the aim was to make that, to make EBM an EBM, and not just an evidence-informed medicine, but evidence-based medicine, and therefore to use this as a tool for clinical decision-making. And the randomized control trial was elevated for that purpose by people like Sackett and Guyatt and all these guys. They did elevate the randomized control trial. The randomized control trial, based on our conversation here and what you just shared, which I think are very good thoughts, as far as I'm concerned, it's really its main value, and I said that previously, is in terms of shared experience. It's really nothing more than a parallel concomitant case series, okay? And then you can look at descriptive statistics and draw your conclusions without having to resort to any statistical inference about p-values and whatnot, or pre-specified thresholds and so forth. It's just shared experience. Now, if you look at it that way, you say, okay, it's nice to have shared experience, historically, sort of parallel groups. But at the same time, the process of having parallel groups that are randomized and so forth, you lose some information that you would have otherwise if you just did your own case series and used your own experience and your historical recollection of because then you can include all comers, for your own case series, and not have to worry about specifying entrance and exclusion criteria, which then reduce the applicability of your RCT to other things. So I think the RCT is fine, but it's by no means the end all be all of things, and should not necessarily be at the top of a hierarchy.
What we should understand is it just conveys an average relative efficacy in a large group of people with placebo regards to therapy, that if you call shared. Obviously, RCTs cannot predict the response. I mean, it can better be done if you have repeated crossover trials, which are, which are rarely done because, it is difficult to do them. Or in real life practice, when I see the patient again and again, I know how he responds. Then again, that is why predicting a response is difficult. But again, that is what that there are no limitations of RCT. So obviously it has to be mixed with practice and yes, I mean, they help us in, for example, Women Health Initiative trials. There are examples where RCTs have helped and changed the practice quite a lot. But because most people, as Anish said, I mean, you might be doing it in a certain way, but I would believe that you are an outlier if people are taking if their people are, you would say that people are doing it because of the EBM movement. They have turned into, zombies, I mean, or something like that. I mean, but I would believe that even before EBM, people were doing all sorts of things. People would be doing all sorts of things. For example, I will give you an example. In India, we have this dengue virus. There is a big epidemic of dengue virus. So it's a dengue arboviral hemorrhagic fever. So people give all sorts of things. Every doctor has his own protocol. So, I mean, and many, like you give papaya leaves and you give everything, right? Kiwi fruits. And so you would like it to, and similarly in tuberculosis, I mean, everyone was running his or her own regime. We didn't have a standard reference. So EBM, at least RCT set that reference for us. So it is always good to have randomized controlled trials because most of the people will, have some sort of crush to, base their evidence on, because not many. I don't think many people exercise their clinical judgment too much. I mean, it is good that if they do, but sometimes EBM gives us a sort of, a big cohort. So comparative cohort, which is well controlled, and that is why not generalizable. But again, the relative, it gives us some idea of the relative efficacy, I think, since it is done in a controlled fashion. That is what I believe.
Anish, go ahead.
No, that is a good point. My mom has, I would constantly be arguing with my mom as I grew up about the various homeopathic.
Or remove device.
Yes. So my mom, as I was growing up, would always talk about, always tell me about all sorts of different remedies. And so, the question is, how do you go about telling her that she's wrong? And so when I was a smart aleck as a kid, growing up in college, I was like, well, Mom, you don't have a randomized control trial to tell me that you're right. So I'm not going to listen to anything you say. Of course, now that I'm older, I find myself on the other end of things. So I know I see the point. But I see what you're saying. I mean, how exactly do you separate out homeopathic folks from chiropractors, from allopathic medicine, and I think obviously there's a lot. Not all bioplausibility is the same. There's a different amount of hand waving that one can do, and certainly these trials are a way of proving that in some sense. But here's the thing. Every time I talk to anyone about this, everyone is like, yes, we know you can't do RCTs for everything, right? I talk to statisticians, they say, yes, absolutely, you can't do RCTs for everything. But then when you ask what I'm finding is that the statisticians, in large part, are the ones that are making us unsure of ourselves. Because what they have said, is that, look, you cannot really know anything without an RCT. So that's where this comes from, right? That's where this, well, I mean, who cares about learning, biology or pathophysiology in medical school? Just learn statistics, because the question is it something that's significant? But when I try to push the statisticians, right? So I sent the story of, the second blog I wrote was on the story of ECMO, right? And it's a fairly, I think, somewhat gruesome story, in that you had strong, really, really strong biology that showed that, these children were dying because they were unable to oxygenate, correct? They weren't able to get enough oxygen to their bloodstream. And here you had this intrepid surgeon that had come up with a fairly invasive way of maintaining ventilation, maintaining oxygenation. And in a case series that he had where, mortality was something like 85 to 90%, right? Now suddenly, 20% was mortality. And they knew, that whole team knew that this was amazing, that this was something that was saving children. But yet he could not convince anyone, because at that point the EBM movement had taken hold, and he had to do some type of a RCT, and they did an adaptive design trial, that's discussed more thoroughly in the blog, which meant not 50-50 control and therapy, but it was probabilities that changed based on how each subsequent patient did. And it ended up that one person was sent to the control arm, and that poor child died, and 9 others went to the active treatment, which was ECMO, and those folks lived. And when he published that trial, by the way, most folks didn't want to publish it. When he published that trial, people didn't believe him, because it was adaptive design. There's only one person in the control arm. So another trial was done where more people were put into a control arm. And so I think history would tell us, that's history from the 1980s. There's history in terms of the PFO trials, right? Despite the fact that you had RESPECT being what it was, and despite the fact that guys like me were like, oh yeah, we're done, we don't need anything else really, you have 2 more trials. And again, a total of 26 patients went into an antiplatelet only arm with a stroke and a PFO, and a large PFO, and they all had strokes. So when you try to push statisticians to say, hey, will you listen to me and say that in these patients we should not randomize these folks, they say, no, we need something. So I don't know how do we find ourselves out of this mess, Anupam, without hurting patients, and without kind of battling against logic.
So if I may comment here, because Anish, I reread that blog of yours on ECMO yesterday.
Yeah.
And actually what struck me is that it's an example that predates the EBM movement per se. It developed in the late 1970s and early 1980s. So you had people pushing.
Yeah, I think the trials were mid-80s though. So I think this had taken hold at that point. Or Sackett. You know better than me. Sackett was, I thought, late 70s, right?
No, Sackett was it's late 80s, and the first papers in JAMA came in the 1990s.
Okay.
The term evidence-based is from the late 80s. Okay. So obviously, people were pushing back against someone's clinical successes and started to demand a clinical trial.
Right.
Even before it was really in our consciousness that EBM, that clinical trials are the way to go on everything. And that's, to me, that's interesting, because there seems to be a psychological benefit of having a clinical trial to gauge, in the sense that, if the medical community trusted, I don't know what his name was, the investigator of ECMO.
Bartlett, yeah.
Right. If they had trust in him and so forth, he wouldn't have, or if he didn't need, the approval of the larger community, if he could just offer this to his patients, the practice would have taken off without a randomized controlled trial. Right. But somehow there were some, hardcore skeptics that wanted it proven and demanded it. And that's an example that predates evidence-based medicine. The other sort of historical anachronism that I see is that when people who vaunt evidence-based medicine use the CAST trial as an example of why we should use evidence-based medicine, they say, oh, without evidence-based medicine, look what would happen. But it turns out that the CAS trial was done, again, before the age of, EBM or at the cusp of it. So people knew to do clinical trials, and sometimes they did them for the wrong reason, and sometimes they did them for the right reason. But it seems to me that that decision and those conflicts and whatnot are a little bit independent of what we call the EBM movement that started in the 1990s. And I want to ask you another question, Anish, you specifically, since you're big on bioplausibility and so forth. Imagine you're in the 19th century, 1850s, and a colleague of yours by the name of Ignaz Semmelweis comes and tells you, Anish, you really, really should wash your hands before you start delivering babies. Because in my experience, it really saves lives. Remember, in the 1850s, that was before the discovery of the germ theory of disease, right?
Yeah.
So there's no biological explanation. It may sound like it's a mystical, superstitious belief that Semmelweis has. What camp are you on at that point?
Yeah, I mean,
what camp are you in?
Yeah, no, I mean, I guess it depends on how. I mean, back in the day, like you in order to convince somebody of a certain stance, you use what lawyers do right now. What do lawyers do when they try to convince a judge that they should side with one party over another, right? I mean, so I mean, you will never know. There's never a deep enough understanding of anything. Like, we still sent rockets to the moon. Even though Newtonian physics isn't completely descriptive of what's happening. So
no, but wouldn't you have the
Semmelweis would have had to convince me somehow that, hey, maybe it's not a good idea that you have your fingernails have dirt caked in them, and maybe you should wash them because dirt is bad. I mean, it may be that I wouldn't have agreed because I'm like,
but if the concept of clinical trial was there, and it was in a way, it's been there for a long time, wouldn't you have demanded it? Wouldn't you have said, no, give me a clinical trial? Well, I won't believe it until.
Well, I mean, again, it would have mattered if Semmelweis was some awesome guy who only 5 out of 100 of his births. Of his mothers died, and I was busy killing 50% of the mothers that came to me. Maybe I would consider changing over to what he was doing. Meaning, it would have to have there have to be some source of he'd have to stand on something to say, hey, this is better than something else.
One thing I would like to add as well. I mean, in many FDA gives accelerated approvals in many cases. Yeah. For example, I gave you an example of bedaquiline. I mean, the mortality was higher in that group, right? With the bedaquiline, it still has FDA approved it. I mean, for example, WHO has also approved it on basis of bioplausibility, and accelerated approvals are pretty common. I mean, though the less the more movement guys, they rail against it, but I mean. So what doctors do, I don't, because those who are, those who don't read that much in detail, or those who just stick at NNTs and ARRs maybe, but again, it doesn't require much of mathematics to be, to incorporate your clinical significant judgment, because that is what Sackett says. Okay, he elevated RCTs to a higher level, that is okay, but these guys again said, I mean, before p-values, look at the estimate effect size. I mean, I'm again emphasizing that part. Plus, when a primary outcome fails, you have to again look at many things, right? But what troubles me is that many people, the many leaders, I mean, at least on Twitter, what I see is, for example, there was this Ebola trial, right? There was the drug given in Ebola. So it didn't reach statistical significance where it has a, risk reduction, a mean risk reduction of 60. It hazarded an odds ratio of 0.6, right? So almost 40% risk in death, and it just missed its statistical significance. That is, the boundaries were 0.3 to 1.2, something like that. So they dismissed it all right. I mean, I was way surprised by it when people are excluding, because the EBM founders never wanted us to, to behave. in that fashion. You always incorporate your clinical judgment depending upon the cost, depending upon the patient risk.
Right.
I mean, and that is what they want. That is at least at least I practice it that way. I don't know what the Bible says. I mean, obviously it's.
But Anupam, do you think that it's okay for clinicians to tell statisticians when we don't need RCTs? How do we figure it out? Meaning, obviously, Michelle has a great point. Like, how do you figure out when you need an RCT or not? Like, who says that, or how do we come to that? That's just are you worried that if you say that an RCT is the only way to generate knowledge, that generate true knowledge, that there's equipoise for then almost everything, right?
No,
how do you figure out when there is and when there's not equipoise?
I mean, obviously, the judgment from our clinical practice, the fruits of a newer hypothesis, the intuitions will come, right? But when to do an RCT, I mean, obviously, when there is a higher case fatality, or they say the parachute case, right? There's no need to do an RCT. So there will be debate which thing is a parachute or not. I mean,
that's right.
In high case fatality, so the bar would be low, right? I mean, obviously, people argue that in oncology, many drugs have been pushed there. But in high case fatality, FDA frequently does accelerated approvals. It is a good thing, I think.
Right.
I mean, and so do other drug regulators. It is very different from what book writers and everyone is trying to push. But this is what is happening in real world. You would say that ECMO, but many devices keep on doing development. People who have really skin in the game and who are doing those trials, even the statisticians you are referring to, they have done a lot of trials themselves, and they are very thoughtful about it. I mean, if you engage them in detail, they say that RCT should be done, but again, then adaptive designs came precisely for these reasons, that at minimum sacrifice. I mean, obviously, it is a sort of unethical. Ideally, not even one patient. If there is some evidence, if there's less equipoise, then an RCT should not be newer. I mean, you should have minimum patients in the control group, but control group is the standard therapy of the day. I mean, so obviously, in case fatality rate when it is higher, so then you lower the standards. The statisticians are also, I think, working at it, adaptive designs, and you do it in less number of patients. I think that is the way towards it.
So Anupam, let me ask you a question, going back to what you were saying about in India, the treatments for dengue fever or a variety of, or even tuberculosis. You're surrounded by people who will try a wide variety of things. Mm-hmm. Is there anything wrong with that, as far as you're concerned?
At least in tuberculosis, it was. I mean, what happened was many people added single drug to a failing regime. It was pretty common, and some doctors wanted, rather unethically, wanted to keep their patients. They didn't want to refer them. So they kept on improvising, adding single drug to a failing regime. It was not working. So it was clearly many people developed resistance because of it. Obviously, it hurt their practice a bit. But it is not like old days. At least in Delhi, there is where I practice, there is lots of one patient shifts to other docs, and there are lots of docs. So the relation is also disturbed. So many doctors, in spite of inferior, mediocre practice, they are able to do well in terms of making money or something like that.
But is the problem to begin with that they're in a way unethical, and not so much that they have freedom to try things? Let's imagine an ideal world where all doctors are ethical. Okay, let's just imagine this ideal scenario. Then wouldn't there be a benefit of just trying different things, especially when you don't know what works, you don't have any other alternative things?
Sure.
And because to go back to Anisha's question about how do we decide when RCTs are helpful or not? In my mind, there are two cases, and perhaps maybe just one. The main one is when a good clinician or somebody with experience would be unable to tell from his own experience whether a treatment is beneficial or not. So things like raising HDL to prevent, things that, so there are no symptoms by which to gauge the efficacy of the treatment. Or perhaps the other one is, the case that I gave of Semmelweis, where it seems completely implausible on the face of it. And you want something a little bit more reassuring than just appealing to animal spirits. And so you run a clinical trial, although even there, maybe you don't even need a clinical trial. But otherwise, if on the basis of clinical experience, you can reasonably get a sense for what works and what doesn't work, in many ways, to me, that can be really sufficient. If you're careful, if you're methodical, you can develop that sense. And if you cannot, then you run the clinical trial. But otherwise, if you think that on the basis of your experience, again, provided that you're honest and wanting to do the right thing for the patient, the ability to try different things is very helpful. I think there's a lot of opportunity cost now for not being able to try different things on many, at many different levels. Now we all feel muzzled in what we can do. We are told by the guidelines and by the evidence-based, methods up to the milligram how much we should prescribe for everybody. The anticoagulant, it's so many milligrams and so forth, and we feel that we have very little leeway in discovering and then enhancing our clinical skills, because there's an atrophy in my mind of knowledge, of being able to gauge the patient's response. And I see that, in me, and I see that with my colleagues, and the kind of questions I'm confronted with by other physicians when they ask about, what should I do with this hypertension and so forth. Well, you can try different things,
At least in India, I mean, the EBM movement is not as powerful because we are a poor country. I mean, we take some time to adopt the drugs after US. I mean, I would say a latency of 5 years. So that helps us, till the dust settles down. I mean, so that is the good, I think. I mean, and plus there is, people, okay, they read EBM. EBM is like just an it is not, it doesn't lord over our clinical judgment. That I can tell you for sure. It is way too different in India as from US. And we don't quantify anything. People will laugh at you if you quantify, because I remember when I started my residency, we had these sepsis guidelines and insulin and ICU. There were major medical reversals, right? ICU, you have to have intensive glucose control, and I was laughed at pretty much. Okay, you wait for some time, you see, right? We don't think hypoglycemia, people will die due to hypoglycemia, and I was laughed at by my seniors, and I was very indignant that, okay, the EBM is saying that, and yeah, so they told, no, I'll wait. And this is what happened. I mean, so my seniors, my bosses were right. I mean, they laughed at me. There was there's an old guy who figures things out. That is why I have also turned skeptical a bit skeptical for drugs with incremental benefits. I have turned a bit skeptical. But again, for things which have a high fatality, you go all ends, right? That is my perception of you try everything, right? That is what normal people do, and that is what should be done.
Well, Anupam, I'd like to call this episode India-style EBM, and I approve of it. So I think on that note, we're going to wrap things up here. Thank you very much for joining us. It was delightful. I think we're in agreement, really, on most important things, perhaps even everything. And thank you for sharing your insights and your experience from India. Anish, any parting words?
No, that was great. Thanks so much, Anupam.
Okay, so the audience, I'd like to remind you to subscribe to our podcast, or to find out the show notes, where we will post the 3 blog posts that Anish has penned on the show notes at akadandkoka.com/episodes or episode 14. All right. Thank you very much, and goodbye, everybody.
Thanks. Yep. Bye, Anupam.